Chapter 3 will cover adrenergic pharmacology, and we'll cover it in a similar approach to the previous one on acetylcholine. Namely, we're going to first start looking at the adrenergic junction, the actual nerve terminal, if you want, that makes norepi. And then we're going to be able to place the drug families that work in that nerve terminal. Now you can see as well as I can, this slide is very busy and there's nothing we can do about it. There are effectively, at the very least, 8 families of drugs to place on this diagram. You can imagine your board is having a field day with this one. So as we review it there, we are not going to review every single of these drug families in the autonomic nervous system. You'll quickly realize a lot of them will come in the cardiac section and also in the central nervous system section. As such, I want you to remember that on this page of your book, or at this point in the video, you have an actual site of action diagram for many medications to be matched to when it comes to board question of both cardiac and CNS pharmacologies. Having said this, let's start first with a quick biochem review together. We're going to start the process with tyrosine, use the rate-limiting enzyme tyrosine hydroxylase, which by the way requires vitamin C as a cofactor, to make dopa. This is the same dopa we'll use to treat our Parkinson's disease patient. Dopa actually stands for dihydroxyphenylalanine. So it's an amino acid, phenylalanine, with 2 OH groups on it. Dopa will then be decarboxylated, and when it's decarboxylated, it becomes dopamine. Now, if we were in a chapter talking about dopamine, we'd stop right here, put it in a vesicle, and have a good old dopaminergic nerve to work with. Here, we want to talk about norepi. Dopamine is the immediate precursor chemically of norepinephrine. In the vesicles, that's why it says vesicular, there would be a dopamine beta hydroxylase enzyme to build the neurotransmitter norepi. You know, it means on a histo question, if I make antibodies against dopamine beta hydroxylase, I would actually be staining the norepinephrine neurons in the body, maybe to map them in the brain, maybe to highlight places like locus coeruleus. So it's an enzyme that is unique to norepinephrine containing neurons. That norepi, the rest is identical to any neurotransmitters. It's in a nerve terminal in a vesicle. Upon depolarization and calcium entry, it's released in the synapse, and once in the synapse, it works on receptors. It will work on both alpha and beta type of receptors. Look, if you want to be even a little bit more picky than we gave you here, you may want to add in your book alpha 1 and beta 1. But don't worry, we're going to see these subtypes afterwards. How do I stop the effect of norepi? It could be degradation by the COMT enzyme, but the primary mode of termination of neurotransmission by norepi is reuptake. That big yellow arrow points to the fact that norepi will be taken back up from the synapse and put back into the nerve terminal. When it comes back into the nerve terminal, it is not placed immediately in a synaptic vesicle. It will actually become the mobile pool of norepinephrine. The mobile pool has its name because you can move that norepi. Certainly you would like to move some back into the vesicle where you have a secondary reuptake system to put it back for recycling so that then you don't have to make it from scratch. But then mobile means it could also move back out. And it can move back out either using the reuptake pump in reverse or simply by diffusion. You see, the idea is just like all chemical. As I'm bringing more and more inside the nerve, I have less and less inside the synapse. And I'm creating a gradient. You know as well as I do, molecules like to go down a concentration gradient. That mobile pool could then be dangerous because a sudden release of norepi that is unwanted, uncontrolled, could result in excessive cardiovascular responses. So we'll talk about this with certain drugs that we'll call releases. Who controls that mobile pool for us? A big enzyme called MAO. MAO for monoamine oxidase, and it is primarily MAO type A that would work on this mobile pool. As I'm looking at MAO enzymes, their primary role being to digest mobile pool, it should allow me not to suffer a massive release of that pool, providing I don't block MAO enzymes. Well, you pretty much have a good understanding just of the biochem and the physics aspect of that synapse. Let's put some drugs. First, just like we did with the acetylcholine neuron, you remember indirect acting versus direct acting? If you do, who would only be direct acting on this diagram? If you're saying 8, you are absolutely right. Agonists and blockers of alpha-1 and beta-1 receptors. There's no doubt there would be the primary drugs that we're going to review right now because they are direct acting. They don't need the presence of a neurotransmitter like norepi. They don't need the presence of a nerve terminal in order to do their job. That tells you that all other drugs from 1 through 7, these are indirect acting drugs. They are all dependent on an intact synapse to cause their pharmacology. As we're looking at this, first indirect, methyl para-tyrosine. With a name like this, it's a tyrosine analog. You see where number 1 is? Above the enzyme tyrosine hydroxylase. This is a drug a little bit like hemicolinium on the acetylcholine synapse, a drug that is only tested with one point in mind. Where does it fit on the diagram? This is not a chemical we use clinically, but as a tyrosine analog, it will block tyrosine hydroxylase. If you block hydroxylation of tyrosine into DOPA, down the road you'll decrease levels of norepinephrine being made, which will decrease levels of norepinephrine being released, which in turn should decrease alpha and beta receptor stimulations. Okay, that's methyl para-tyrosine. How about the next group? As you look at the next group, I want you to learn it in conjunction with the number 3 drugs. Always think of MAO inhibitors as being relevant with releasers. This is a section we'll cover in the central nervous system, but here we see the site of action. An MAO inhibitor would inhibit the enzyme MAO, therefore increase the norepinephrine mobile pool. A releaser is a drug that causes the release of that pool. What would happen if the two chemicals were together? Then you would have on one hand an enormous mobile pool and on the other a chemical that can release it. You would get tremendous stimulation of both alpha and beta type of receptors. As such, you would get exaggerated cardiovascular responses that would be life-threatening. It is the drug interaction between MAO inhibitors and releasers that we're going to be after clinically. So keep it in mind. We'll mention it again in the notes in ANS, but we'll review it in detail when we review MAO inhibitors in the CNS. You know, MAO inhibitors are one of the modalities of treating depressions, particularly atypical depression that don't respond normally to reuptake blockers. And talking about reuptake blockers, look who comes as number 4. The indirect acting drugs we do use in treating depression. They may block reuptake of norepi. If they block reuptake of norepi, they directly cause an acute increase of norepi in the synapse, once again causing overstimulation of alpha and beta receptors. All these drugs right now, MAO inhibitors, releasers, reuptake blockers, are drugs that belong primarily to the central nervous system section. Just have an idea where they work and the fact that they are indirect acting. As we're going to go to numbers 5, 6, and 7, we are about to look now at drugs that we will review again, but in the cardiovascular section. Let's first work with alpha-2 receptors. Look where the alpha-2 receptors are located. They are not located on the effector cells. They're located presynaptically. Presynaptic receptors are also known as autoreceptors. And these autoreceptors, their primary job is literally negative feedback. This negative feedback is a control that occurs on the synthesis and the release of norepinephrine. So be very careful here. If I stimulate an alpha-2 receptor, I would enhance this negative feedback. So what would be the result by the end of it? What the result would be with less synthesize and less release would be a drop in norepi and a drop in alpha and beta stimulation. Alpha-2 agonists, we're going to see them in the cardiovascular section. They're going to be some of our drugs we use to manage hypertension. How about alpha-2 blockade? If we block an alpha-2 receptor, look, obviously now you would actually cancel the negative feedback with an alpha-2 blocker. And with no negative feedback, you would result in too much norepinephrine synthesized and released and excess alpha or beta stimulation. Well, beyond these drugs that we'll review in cardiovascular are two very old drugs that are also seen in the cardiovascular disease, reserpine and guanethidine. Reserpine and guanethidine work at the level of exocytosis from vesicles. That's all I'm going to say for right now for these old drugs. So which are the drugs that will primarily be reviewed in this section? It's the drugs that work at point 8, the agonists and blockers of alpha and beta receptors. So let's review in a similar fashion to looking at muscarinic and nicotinic receptors, now the alpha and beta receptor subtypes. Realize that it is these tables that hold the key to the answers on your board questions. It is understanding well where are the receptors and what they do that will literally explain to you down the road, if I call this drug an agonist or a blocker of alpha-1 receptor, this is the list of things I should expect to see. And from there, we'll pick on what we think has clinical relevance in pathologies, and whatever we leave behind will become side effects of such medication. So look at an alpha-1 receptor. An alpha-1 receptor is a receptor that is primarily found on smooth muscle. And as it's found on smooth muscle, it's relevant to remember from our general principle that this was a GQ coupled receptor. You remember GQ coupling? It does mean increased calcium. And increased calcium in a smooth muscle invariably increases contractility. So now the job is, what type of smooth muscle? Well, the first one we worked on in our fundamental concepts was the radial muscle of the iris. And contraction of the radial muscle, recall, caused mydriasis. You know, if you want to be complete, we would say mydriasis without cycloplegia. And the reason it's without cycloplegia is because there is no effect on accommodation of alpha-1 receptors. So that's just for you not to confuse it down the road with muscarinic antagonism, where the mydriasis was associated with blurred vision. That's not where the money is, though. Where our money is here is in the effect on the vascular system. Alpha-1 receptors predominate in any vessels. We picked on two big ones, arterioles and veins, based on their actual hemodynamic relevance. Arterioles, if I cause contraction, I will increase my resistance. By decreasing the radius, increase TPR. Increasing the TPR is going to increase the afterload on my heart tissue. Increasing the afterload is always associated with an increased diastolic pressure. Essentially, I'm saying with alpha-1 stimulation, I'm going to make the heart work harder. That heart will work harder because it has to pump against increased resistance. Can I use vasoconstriction of arterioles? You bet. Imagine you had a patient in shock with vascular collapse. You'd be very happy to increase vascular tone. But could I at the same time cause too much vasoconstriction and cause ischemia? Absolutely so. If you vasoconstrict too much, hypoxic injury to tissues could occur. So an alpha-1 stimulation must be taken very carefully, obviously. How about the veins? Veins are capacitance vessels, not resistance vessels. And remember from your physiologists, about 80% of our blood volume can be found in veins. So if I contract large veins, contraction of large vein is going to increase venous return, which increases the preload. If I fill the heart more, stalling told me to compensate, the heart will pump harder. So increasing the preload will increase the systolic blood pressure. Put the two together. I'm increasing diastolic and systolic blood pressure when I stimulate alpha-1 receptors. You remember pulse pressure? If I call it PP, pulse pressure, it is actually the difference between systolic blood pressure and diastolic blood pressure. Well, would it be changed by alpha-1 stimulation, or would it remain the same? Look, if I increase both, it will remain the same. There will be no change in pulse pressure, simply from the standpoint that I veno-constricted and also arterial-constricted. Well, that's the key point. That's why I put it in red right here for right now, the vascular effect of an alpha-1 stimulus. Now, how about some other little stories in here? Well, just in passing and to put icing on the cake here, there are alpha-1 receptors on sphincters of GI and GU tract. You would expect contraction. So for the urine, it would mean urinary retention. Or maybe we'll use that for certain forms of urinary incontinence. In male sex organs, vas deferens, epididymis, well, actually emission more than ejaculation, to be anatomically correct, would potentially be triggered by alpha-1 stimulation. Now, I always love to say we're not planning on using an alpha-1 agonist to cause an individual to ejaculate all over the place. But much rather, what you should be concerned about is when we use alpha blockers, there will be a sexual dysfunction. And behaviorally, what is the result of sexual dysfunction in our patients when it's due to drugs? You know as well as I do, they're going to decide, the hell with this drug. I don't want to take it. And compliance becomes a big problem with alpha blockers, possibly because of decreased sexual function. In the liver, there will be some effect on glycogenolysis, but we'll have a beta receptor to work on for that, the beta 2 receptors. Now, the next point that you may want to highlight with the same color you've used in your book for arterioles and veins is the kidney. Alpha-1 receptors can control renin release, and you are reading correctly here. Alpha-1 stimulation decreases renin release. More to come on renin regulation by sympathetic when we look at beta-1 receptors. How about an alpha-2 receptor? Well, an alpha-2 receptor, remember the diagram. It's a receptor that is primarily presynaptic, pre-junctional if you want. And alpha-2 receptors cause negative feedback. If you recall, alpha-2 receptors are GI coupled. They lower cyclic AMP. And if they're GI coupled, lowering cyclic AMP, they play an inhibitory role on both synthesis and release of the neurotransmitter norepi. Well, so far as this is concerned, that's as far as we're going there, but you could already tell me, maybe if I have less norepi, I have less alpha-1. Less alpha-1 should mean what for my blood vessel? If you're saying I would no longer see vasoconstriction, I would dilate, lower my blood pressure, you are absolutely correct. Alpha-2 agonists will be used in a cardiac section as antihypertensive. So here's what I would like you to highlight and know well. Alpha-2 receptors are not only presynaptic receptors. They are also found on platelets and mediate aggregation. Look, it's not like a platelet is attached to a nerve terminal. It wouldn't be able to circulate, would it? No, rather, these alpha-2 receptors are for epinephrine to work on. And epinephrine, as a stress emergency type of hormone, does play a role on aggregation of platelet and the thrombosis pathway, simply in the emergent situation where there might be some life-threatening hemorrhaging. So besides the constriction through alpha-1, there could be also platelet aggregation to form a temporary thrombus and prevent bleeding. Why highlighting this? What would be something to worry about in a patient who has hypertension and the use of an alpha-2 agonist? You know, it would mean this is a drug that also triggers platelet aggregation. What if this patient with hypertension had an atheroma plaque in a coronary? I don't want to have a drug that causes aggregation, do you? So it tells you an alpha-2 agonist that comes with a potential side effect, which is to promote aggregation. Look at another one. There are alpha-2 receptors on the beta cells of a pancreas, and through the GI coupling, there will be a depressed insulin secretion. Now, this is another story I will worry about. If I was worried about atherosclerosis and what aggregation would mean, what do you think is the disease I'm going to worry about if I was using an alpha-2 agonist to treat hypertension, knowing that in the pancreas there's a decreased insulin secretion? Yeah, I have to worry about diabetes. An alpha-2 agonist is probably not the best thing on the planet to give to our diabetic patients. If you further suppress insulin secretion, you are worsening the diabetes in this patient. So if you know alpha-2 on these 3 locations, I think you can already have a clinical feel as to what we may have to worry and the type of questions we can build around alpha-2 receptors. Let's go and check out beta receptors now. And our beta 1 receptors have the advantage not to be in too many places. They're primarily found in the heart and in the kidneys. In the heart, you find them everywhere. That is, SA and AV node, where they will oppose the muscarinic M2 receptors. As a matter of fact, whereas M2 was GI couple, beta 1 is GS couple, so that the increased cyclic AMP will undo exactly what the muscarinic stimulation would have done. And what is really critical here is that unlike parasympathetic, there is also finding of beta 1 in the muscle itself. That is both atria and ventricles. So when you look at the response, you expect tachycardia, the positive chronotropy. You expect the increased conduction, the positive dromotropy. But the other thing you do expect from beta 1 stimulation is an increased force of contraction, a positive inotropic effect. With a positive inotropic effect, I know you're already thinking, that's it. I will use beta 1 stimulation in my people with cardiovascular shock. You are absolutely right. Pumping the heart is going to maintain the cardiac output. But you think of it also differently maybe. If I do that chronically, I'm increasing oxygen demand on the heart. And beta 1 stimulation, could it worsen angina? And could it worsen myocardial infarction? Of course it could. Rather, beta blockade might be the answer in people with angina and MI. So you start having a fear, I'm hoping, that beta 1 receptors are going to be a critical target for us to play with in cardiac conditions. In the kidney, I'm very excited to read about the increased renin release because I can now integrate the two responses. Alpha 1 suppresses renin release, beta 1 increases renin release. Hey, that means literally the sympathetic nervous system has a say on renin production. Who's gonna win? If you look in the margin of your syllabus, you will read that beta receptors are usually more sensitive than alpha receptors to activation. So imagine today you were in physiology. What would I tell you sympathetic does to renin? If betas are more sensitive than alpha, I would tell you sympathetic increases renin production. That's totally correct. But what if today I'm in pathology and I have a patient with a pheochromocytoma? Huge amounts of norepi and epinephrine are produced. Massive hypertension follows. It means the alpha 1 responses are predominating. What would then be the renin response because of that? It would be decreased. You know, the way I want you then to understand that alpha 1 response is that it's a little bit like a safety valve. If I already have plenty of alpha 1 responses to increase my blood pressure, I absolutely don't need the imposition of renin, angiotensin, aldosterone to also vasoconstrict and increase blood pressure. It would be so much blood pressure increased that the end point would be probably dying of a hemorrhagic stroke or certainly dying of the conditions associated with severe vasoconstriction. So when alpha 1 is around, there's no renin. On the other hand, when beta 1 is around, beta 1 is primarily causing your ventricles to contract and increasing cardiac output. Having the help of renin, angiotensin, aldosterone on the vascular system then becomes a complementary effect that we will like about the renin. As we now look at the beta 2 receptors, notice what's written, and I can't read. Can you read for me? Mostly not innervated. Do you recall talking about this in the first chapter of this section? If it's mostly not innervated, who cannot reach a beta 2 receptor? Norepinephrine, which is a neurotransmitter, cannot reach this receptor. This is the receptor for epinephrine. And I want you to think of the beta 2 receptor as part of the flight, fright, or fight responses. Also, I want you to understand the role of epinephrine in our body is primarily to come out of the adrenal medulla under these situations, not so much to help norepi, but rather to oppose itself to norepi. Let's take an example. Every single blood vessel has a beta 2 receptor. And beta receptors, let's recall, are more sensitive than alphas to stimulation. Those beta 2 receptors, they will mediate vasodilation. They will decrease total peripheral resistance. In effect, they would decrease diastolic pressure, decrease afterload. What's the idea behind this? Well, let's think that you are having your flight, fright, or fight response right now. If it was up to norepi, what would happen to all of your blood vessels? Through an alpha-1 stimulation, they would vasoconstrict. Next thing you know, you'd have no blood supply to your heart, you'd have a heart attack. No blood supply to your muscle, you'd have a cramp. No blood supply to your brain, you'd have no clue what you're supposed to be doing. So who's there to oppose itself to norepinephrine and impose a dilation of the vessel, particularly to critical organs that need more oxygen supply? Epinephrine through a beta 2 receptor. So always remember, beta 2 receptors will vasodilate all blood vessels, and it is more sensitive than alpha 1 to stimulation. Other smooth muscles with beta 2? Well, the uterus would relax thanks to beta 2. That's why we'll use beta 2 agonists to prevent premature labor in pregnant ladies. And very importantly, just as much as the blood vessel, highlight well your bronchioles. There are beta 2 receptors on the bronchiole, and relaxation of the bronchiole will be a big role for beta 2 agonists to be used in asthma. So bronchodilation, vasodilation, these are your primary beta 2 mechanical effect on smooth muscle relaxation. Beta 2 receptors, by the way, are GS coupled, and they increase cyclic AMP. And that increased cyclic AMP is the one associated with the dilation or relaxation of smooth muscle. Now, when it comes to biochemistry, this is where you'll find other big points for your beta 2 receptors. Beta 2 receptors are going to be quite relevant really to stimulate three major pathways in the liver. Now, your notes primarily put increased glycogenolysis as they have in the book that you're using right now. But you'll see later on in the text, and if you want to add it with me right now, it's fine too. It will also increase gluconeogenesis, so that really epinephrine will do all it can in order to increase circulating blood sugar, in order to feed extrahepatic tissues such as the brain, such as also the fast twitch fiber. And notice for that matter that the skeletal muscle glycogenolysis is itself increased, potentially to the point of causing tremors when we stimulate these receptors. The gluconeogenesis and glycogenolysis cannot function unless you've also increased lipolysis, which is the mobilization and also the degradation of fat by this liver cell. Recall in biochemistry that unless your liver burns fat, there is no way it has enough energy, enough ATP to produce sugar. Well, all these big biochemical pathways are actually stimulated in part by epinephrine. Other key hormones, by the way, would be glucagon and cortisol. How about the effect on insulin? This is another story that you'll want to highlight well with me. In the pancreas, there is an increased insulin secretion through beta 2 stimulation. So let's cover this a little bit. You remember an alpha 2 receptor was associated with decreased insulin secretion, but now a beta 2 is associated with increased insulin secretion. Who's gonna win? If epinephrine is out, beta 2 has to win, because beta receptors are more sensitive than alpha to stimulation. So as such, make sure you remember insulin secretion is slightly enhanced by epinephrine. I know to some of you initially it'll seem counterintuitive. It'll be like, how can I stimulate gluconeogenesis, glycogenolysis, and also tickle insulin production a little? Well, this is the key point. It's a little bit, okay? We're not talking switching to the insulin world of biochemistry here. We're talking about the fact that if we put sugar in the blood, we're going to need some insulin to allow its uptake and to allow its burning. Otherwise, the glucose would have nowhere to go. Well, you know, most hormones of the stress phase, whether it's glucagon, whether it's epinephrine, they actually cause a small increase in insulin for that purpose. In your book, we've also added D1 receptors. Now, D1 receptors are not part of the autonomic nervous system, but the reason we've put them there is that we mustn't forget that dopamine, first and foremost, is the precursor of norepinephrine. You remember that dopamine becomes norepinephrine once I put another hydroxyl group on it, thanks to the dopamine beta hydroxylase I find in vesicles. As a precursor, it is also used as a drug. And if you look in the margin of your book, you'll find a little note about the use of dopamine in shock. Dopamine will work in the periphery on D1 receptors. These are GS-coupled receptors, just like beta-2, that will increase cyclic AMP. And on the vasculature, they'll result in vasodilation. Where do we find these receptors? Appropriately for shock, look at this. You find them in the kidney. Improving kidney blood flow and filtration rate is critical to our management of a shocky patient. You find them also in coronaries. And with dilation of the coronary, you improve blood supply and oxygenation of the heart muscle. Well, when you put this together, there's no doubt from the D1 receptors alone, I will be happy to have dopamine stimulating them. But as I increase the dose, dopamine is very similar to norepi. It's only different by a hydroxyl group. So you know what's going to happen? I'm going to start binding to beta-1 receptors and then ultimately alpha-1 receptors. So that now I also add on to it some adrenergic pharmacology to the drug dopamine. It means as I'm titrating my patient with increasing dopamine dosages, I will go from improving blood perfusion to heart and kidney to increasing the heart contractility and the cardiac output, and if needed at higher doses, some alpha-1 agonist activity to maintain systemic blood pressure. It makes dopamine a very good drug in our crash carts in the hospitals to try and maintain hemodynamics adequate in people with shock. You also see another drug in your margin, which is the drug phenyldopam. We've added this drug in this new version of Kaplan Notes because phenyldopam is actually a D1 agonist. It is really not used in shock. It's primarily used in management of hypertension. Notice in the name, dopam for dopamine. So it doesn't make it too hard of a drug to work with the day of your boards. Well, before we put drugs in, let's just recall in one table the key G protein linkage of alpha and beta receptors. We've explained alpha-1 through that GQ coupling would increase calcium and cause increased contractility. Alpha-2, primarily presynaptic and GI coupled through decreased cyclic AMP, will increase the negative feedback on synthesis and release of norepi. And all beta receptors and D1 receptors are GS coupled, increasing cyclic AMP to do their jobs. So I'm looking at this. I don't think it'll take a rocket scientist and to understand that if your boards want to test about G protein coupled receptors, there's no better spot than using adrenergic pharmacology. Look at this. You have every single type of medically relevant G protein coupled receptors in one system. So expect this as a step one question. I'll give you a drug and then you'll tell me what is the effect inside the cell. And you'll choose whether it's IP3-deacylglycerol-calcium from alpha-1 or whether it's a cyclic AMP change from alpha or beta stimulation. Well, you are now ready to put drugs into that system.